Good afternoon. My name is Joey Richardson. I work at UAB, Section of Surgical Oncology. I'm a RN CCRC, which is supposed to be a Certified Clinical Research Coordinator. Been doing this about 10 years. And my topic today is recruitment and retention. So let's get started. I'll go over the objectives real quick. And it's mostly looking at the common barriers that you have to recruiting, the key issues of enrollment, and retaining your patients, your strategies for doing this, as well as guidelines that affect how you advertise. All right, this is the pyramid approach. You can look at this at your own. It gives you an idea of where everything is. Notice at the very top it's common sense. That's the biggest thing a coordinator needs, is common sense to understand how best to enroll subjects and keep them in the study. Everyone has to have a slide that has all the websites. These are the websites of the pharmaceutical industry and of the different government agencies. Also, it talks about the IRB, and you'll see it again talking about recruiting material for the IRB. Everything has to be approved through your institutional review board before you can advertise. Okay, what do you need to know? Obviously, you need to know your own institution policies, what kind of behavior you're looking at or health aspect you're looking at for your clinical trial, what the protocol entails and what it is, what certain conditions they want to look at, what their actual hypothesis is, the different procedures, do they correlate with your SOPs, and bioethics and good clinical practice. Okay, these are all in a rotating, these are in a circle, and you'll have some more than others, but these are something you need to look at when you are looking for a good protocol to enroll to. HIPAA, I'm not going to cover it much. Everyone who is doing medicine now, either in clinical research, has gone over HIPAA. So I'm not going to beat a dead horse, so we'll just go on. There we go. I had to get my slides back in order. Where you find primary patients, depending on what type the trial is, if it's an inpatient trial or an outpatient trial, most of the time you will use a clinical database of your provider, whoever your PI is, sub-Is, the institution that you work for. You'll look at specific clinics to get your patient population to enroll. Also, very last, they also have physician referrals. These usually come as an aspect of clinicaltrials.gov, where patients are looking for clinical trials. Say with what I do in oncology, they're always looking for clinical trials, especially if they failed several lines of treatment. So they will come to you themselves without advertisement, because clinicaltrials.gov is not an advertisement. Clinicaltrials.gov is a government-based data bank of all clinical trials that are available. And then advertising at the last. Ethics fees, these are typically something that you get from your IRB. Now, there are certain institutions I've known of in the past that they don't agree, and I know our institution here at UAB, we do not accept referral fees or enrollment bonuses. Some places don't even, they consider it coercion if you pay someone a stipend for coming in. Some places I've known, Cleveland Clinic's one of them, that had a friend from there several years ago that explained to me that they don't even pay for parking because they consider that coercion in their IRB. So you need to find out what your IRB's ethic policies are, and if you have a question, you need to ask them before you submit something to them, because if you submit something that's against their policies, it's not going to be approved at all, and it's going to cause you a lot more headaches. Always remember the conflict of interest. Every clinical trial will have a designated conflict of interest sheet that you fill out. Some do it on the web. Some actually have a paper sheet. Some sponsors want you to fill out a web and a paper sheet. These are things you need to be aware of when you're looking at recruiting in a trial, how much time and what have you. Okay, when you explain to a patient to recruit them, you always have the questions they're going to ask. Most of the people will say yes because they believe this is a saving grace for them, especially in what I do in oncology. A lot of times this is their last ditch effort, and so they tend to strive to find anything they can. They also believe they get better medical care. And I like to think when you are an individual research coordinator nurse with your patients, they do get an individual nurse for them to answer their questions, to talk to them, and be able to spend time with them. They feel like they have an active role in the care that they're receiving. They can tell you what's going on. They can get explanations from you. Some people actually delve into how sound is the research, what's the hypothesis behind it, especially here in an academic society where you have a lot of patients that come from academia. You will see a lot more patients knowing of the research, wanting to find out more about it, and wanting to participate just to see how it's done. And some people actually look at it as contributing to their children and their grandchildren by a valuable research idea. Now, the reasons people say no, most people are scared of the risks. They don't know whether it's a new medication. They don't know whether they're getting a placebo or sugar pill, as they say it here in Alabama. They don't know what kind of side effects. They don't know, does it actually work? Would I be better off having the standard of care therapy or trying something new that has not been proven? Most people, too, here, it's very inconvenient, especially if you have a middle-aged demographic where they're still working or they're young working and they have a social life and they have this. Being in a clinical trial, depending on the number of visits, it can be very inconvenient, very time-consuming. Also, I think I've been in research probably 10, 11 years. I have yet to see a positive TV series or show or movie that portrays research in a positive light. Usually it portrays research that we're all Dr. Jekyll's, Mr. Hyde's, or Dr. Frankenstein's. But that's what people see, and that's where people a lot of times get their information on what clinical research is. And notoriously, if you turn on TV and you look at CNN and you look at MSNBC, they're not going to tell you about the new life-saving research except in a real quick blurb. But they will tell you about the researcher that injected people 1,000 times over without consent, because that sells. Also, when someone comes in, if you're one person and a cut-off T-shirt and a dirty lab coat, and you have nobody else in your office to help you do research, people are not going to really trust you. So you need to have a very well-equipped staff and a very understanding PI to really make the research work. Okay, these are more barriers. This goes over some of the same things. These are things that you want to tell the patient. These are things you want to look at too when you're doing your study. If you're doing a study that is for the patient and they have travel problems, it adds more procedures, longer appointment time, you need to look at that before you delve into it. You need to make sure on your staff that you understand the consenting process, you understand how difficult it is. Certain studies want a specific type of patient. Sometimes those patients are a specific either genetic marker or biomarker that they have to have, say in a breast cancer patient, and those people are rare, as we say in Alabama, rarer than hen's teeth. So if you delve into something and say you're going to enroll 20 patients in something like that, and you screen 35 patients for every one you enroll, it's not going to be a very fast or very quickly accrued study. Okay, this was something I found online about the clinical trials barriers, what people thought. The most amazing one I think, and I hate to read to you because I know you're all much more intelligent than I am, so you can read this, but it says about 85% of people with cancer were either unaware or unsure that participation in clinical trials was an option. A lot of people didn't even think it was an option to be in a clinical trial. Though about 75% of these people said they would have been willing to enroll had they known it was possible. Now, sometimes this is families not wanting to admit patients have cancer. Sometimes this is the primary care physician not wanting to send them to a center where they do a lot of clinical trials. There are a lot of reasons, but a lot of reasons the patients don't know they exist. And then if they do, it's like I said earlier about the media portrayal of certain clinical trials, they don't want to do it after that. And they don't see the actual benefit. you can read all this. The one thing I wish I could see y'all, but the biggest thing I hear from people is family members telling their mother or father or sister, brother, whoever I'm interviewing for a possible participation, is you don't want to be a guinea pig, And, I like to usually counter that by saying, well, everything we do, somebody was. And that's why the care has improved so much in this country, is somebody was a guinea pig. Okay, let's go to the planning for the feasibility of a study. How is the interest? Does your PI, does your institution have an interest in a study? The second aspect is, what is the inclusion criteria? Like I said earlier, is it too strict? Is it above standard of care? What does it look like? If you look at your patient population and you look at your inclusion-exclusion criteria, does it work? Do you think you can find patients to fit that population? And it's really difficult sometimes. And one of the slides later on will show you about enrolling in a standard study about the numbers. Next, is it complex? How acute do the patients have to be? How acute does their procedures have to be? Do you have conflicting studies? Do you have studies that are already there, that are already enrolling, that this one would compete against? And you'd have to say, well, this patient goes to this study, this patient goes to that study, so you don't, you're not maximizing the potential of either study. Limiting factors of the disease. In oncology, you have a lot of limiting factors depending on the type of cancer they have. Pancreatic cancer has a shorter life. Some lung cancers that are in metastatic stage have a shorter life. So these patients don't reach the inclusion criteria until they're not able to participate in the study. Or if they participate, it'll only be a week or two, and it may not benefit them at all. Try to look at what foreseeable problems you see. If you're, say, like we're here lately, we've seen at this time frame, it's the 2015, and Boston's getting blanketed. If they were looking at starting a study and it was going to have a lot of people traveling in, they might not want to consider starting that right yet, because you would have automatically foreseeable problems of people not being able to maintain their appointments. Do you have the population? Do you have the patient population that will sustain and fulfill enrollment for this trial? Any compliance risks? Do you have a sub-I that has, that has a conflict with this institute, with the company that's doing the study, or has a conflict with one of the other investigators? Is the budget too high to where you would be afraid of thinking that the IRB would think this was paying you to have the research the way they want it? Or is it too low to where you're going to lose money on the study? Now, granted, when I say that, I'm not trying to be a salesperson and make money, but if you do a research study where you enroll someone and it costs you $1,000 every time you enroll somebody, you can't do that study long. It's financially impossible. And that will determine whether you go or no go. Have a plan. When it talks about pre-planning, that's looking at getting your documents together, talking to everyone, maintaining a schedule of meetings, because the FDA now requires that your PI has a bi-weekly or monthly meeting about a study while it's enrolling, so that he knows everything that's going on. He or she knows everything that's going on. In your enrollment phase, make sure you understand that you have a plan for how you're going to review patients, how you're going to check for inclusion, exclusion criteria, how you're going to consent these people. Make sure you have your documentation. Are you going to use completely web-based ECRFs, or are you going to be using paper ECR or CRFs? And then retention. How are you going to gauge how you retain these patients? Are you going to set up a QA system to where you question them? Do they have concerns? Or are you going to just do a verbal or a phone call? But have all these things set, or have an idea of them before you start your enrollment. Worksheets, everybody has worksheets. These are just a part of what you will see, especially if you do industry sponsored. They will have all these for you. They will have your inclusion, exclusion. They'll have screening logs. They'll have patient logs. They'll have visit logs, drug logs. They'll have logs for your logs. So it's a little bit of everything. But make sure they follow what your SOPs say. Now, another little FYI, FDA does not require you to have SOPs or standing operating procedures. However, in the event they do investigate you, if you have an SOP and you do not follow it, that will get you a 473 letter real fast. Developing and executing plan, these are things I've already covered. Knowing how to use your tools, knowing what your pooled resources are, knowing what your time frame for recruitment is. If you open a study in June 1st and the recruitment time frame, everything you're looking at is going to close July 1st, it's really not feasible to do that, because you may or may not enroll anybody unless it's a really, really easy trial to enroll. And also make sure you have your budget. I know I keep sounding like, you know, all about money, but you have to be able to afford to do the research. Okay, now let's get on the ability of advertising. Right now, you will see more radio ads. You will also see guest spots. You have some research, especially if it's an NCI, NIH clinical trial. You'll see that they're on public service announcements. Cold calls and web postings, they're okay. Typically, sometimes they don't maintain the, they're not, let me just clarify it. They're not worth the time to put in to do them, because the experience I've had with that, cold calls don't usually work, okay? Newspapers tend to work still fairly well, but now in the age of electronic print, it's more than likely going to be an electronic newspaper versus an actual newspaper that you used to wrap fish in. You can also do PTO meetings. Health fairs are good. A lot of times if we have a clinical trial enrolling in an oncology study and there is a group like for pancreatic cancer, there's PanCam. If they have a get-together, a meeting, sometimes we will be there and we'll have it already approved through the IRB that we can talk to them about it. We may not enroll anybody, but we will talk to them about it. And sometimes word of mouth from patients, if a patient knows someone whose family members had their type cancer, in my job, they tend to contact them to find out about what's out there. So you'll see that. Some of these others, office displays, word of mouth. Word of mouth is usually one of the best, but that's something where you have to get it out and you have to talk to people and you have to be willing to listen to them. That's the big thing. You can't just talk and barrage them. You have to listen to them. Okay, these are the different types. I've covered them. Clinical trials, study device, data, inpatient, outpatient. This is just covering what inpatient. Inpatient typically you will see done when you have, I did CV research prior to oncology, and we would review newly admitted patients. We would review patients who were in the ER for certain myocardial infarction protocols that we were doing, and we would go talk to them with the PI or the sub-I to consent them. And then everything they did, they had certain procedures that were followed in-house while they were an inpatient in the hospital. Then they went, when they transferred out of that or went home, then they were followed up on a long-term basis through outpatient. Then you have the specifically outpatients, which they come in for a routine visit once, twice a week for every how many months in the protocol, and you follow them that way. This just goes on the techniques. But one thing I want to comment on here, the commitment from the PI, you have to have a PI that's willing to work with you. You can't have a PI that says, you just enroll them and I'll sign off on them. With the new FDA regs and what they're wanting to look at, they want that PI to know what's going on, what issues you have, what troubles you have, what concerns you have, what concerns the patients have, and it has to be documented. This is going over what I've usually said. I have a certain time frame, so I may not cover all these, but you should have a handout of this and you can go over it. Also at the end, there'll be my contact information, so if you have questions on the slide, please feel free to call me. As you can tell, I'm very shy though, so I don't talk a lot. Okay. Excuse me again. plan, track, evaluate. Most of the time when you do an industry-sponsored trial, you're going to see these time frames. They're going to want to know how long is it going to take you to go from your office to the IRB, how long is it going to take you to go from the IRB to your budgeting people, how long is it going to take you to go through any individual groups, and whatever steps you have, hoops you have to jump through. They're going to ask you what your costs are. How much are your recruiting costs? Is it going to cost you? Are you going to have to pay a recruiting firm to help you recruit? Are you going to have to pay a firm to answer an 800 number to give you referrals? Things such as that. And then what kind of quality of data are you going to have? Are you going to have patients? Are you going to outscreen? Excuse me. Are you going to outscreen your patients and not consent that many, and then have several of those that you consent withdrawal, so you only have a few to evaluate? You have to look at all this and evaluate and follow these up, because these are things that will make a good study or break a good study. Informed consent. As you look at my fancy thing here, my little bar, nothing can be done to the patient related to the research study until the informed consent is signed by all parties involved. Okay, here's what I was telling you about the recruitment numbers. You have a pool of 1,000 people. You pre-screen people, which is essentially looking to see if they have the disease process, if they have the right blood work, what have you, per the protocol. You lose about 400 from there. You look at your inclusion-exclusion. You lose another 250. Then you consent, and they pre-randomize, but yet they fail that. So you end up drop, and then you randomize about 100 and you drop. So you end up with very few out of that 1,000 pool, that probably 200 out of that pool that you start out with 1,000, because of once you go through all the steps. So it takes a lot of people to get 50, 100, even 20 in studies. Okay, I've changed this over from 2006. It was the Center for Information and Study of Clinical Research. This is the industry perspective about clinical trials. Only 70% in 2006 believed that research studies and trials were safe. 51% said they thought they were somewhat safe. 11% said they don't believe they're safe at all. And 7% said they did not believe them to be safe. I take that back. 11 said they don't think they're very safe. 7 said they're not safe at all. And 14, they have no knowledge of the topic. So you've got about as many people who don't know about clinical trials that say that they're safe, or that they don't believe they're safe. That's something we've got to work on. Okay, therapeutic misconceptions. I'm going to cover this real quick. And essentially, when you're talking to a patient, especially in my line of work with the oncology patients, you all know when you talk to a patient, they hear a lot of times, unfortunately, what they want to hear. And what you don't want to do is you don't want to give them the aspects of a clinical trial or a research study when they failed one or two therapies, like in oncology, and they're thinking this will save me. That's a therapeutic misconception, that if they get into this study, they're going to live longer or better. And you will see, if you look at these numbers, most people don't have an understanding of what a research trial is about. Most people want you to tell them that this study is going to make them better. I've gotten to a point now where, depending on what the study is, unless it is something specific to change their standard of care, I always tell them this may not benefit you at all. And try to hammer that part home, because you don't want somebody going out there thinking they've got this research study and it's going to save them, and then they end up in the standard of care arm and it's blinded and they die, because that's where you get the bad rap from research. Here we go. Doctor as healer versus researcher. And most people, they can't differentiate which is which. So that's something your PI also needs to work on when he talks to the patients before they consent. And here's what I said earlier. Where does informed consent? It's when, if you direct advertise for a study, that's starting the informed consent process. It doesn't mean that they've consented, but it's starting the informed consent process. Oh. And these are what we were covering earlier. You can't coerce them. Now, if you have a study to where you put your travel will be covered, your parking will be covered, things like that, that's not really coercion in my opinion. Of course, my opinion, 50 cents will buy you a cup of coffee. But now if you tell somebody, we're going to use this antifungal cream on you and you're going to get $8,000 at the end of the study, I think most IRBs would look at that and say, that's a little coercive, because you can nearly buy a car with that. So these are things you need to look at. You want to leave out implied benefits of the study. You want to leave out the claim that all these are safe. You need to let them know, especially if it's a brand new clinical drug or a brand new device, that these are being looked at by the FDA. They have not been approved. Now that's unless you're doing a phase 4 trial where it's already been approved and you're looking at more data. But in phase 1, 2, and 3, you need to make sure you're specified. This is not approved. And don't ever promise free care. Free care will get you in a whole lot of trouble real fast. Over there are some other things. New drug, new treatment, don't use that. Just evaluating treatments, evaluating a novel idea, things like that where you say it's not new, you're just saying it's a novel approach to the same therapy, but it's an idea. We don't know if it's going to work or not. Do not emphasize the payment. Don't make an advertisement that talks in 9 font or 10 font about all the side effects, and then in 32 font put, and we will pay you $100. That's not good. Don't limit information to what the subject needs to determine their eligibility. Don't say, when you call me, and just briefly go over something and say, oh, well, we can cover that later. Answer their questions to the best of your ability. These are just some actual advertisements that we've done. I'm not going to cover them. You can look at them and see these were actually approved advertisements by the University of Alabama, Birmingham, IRB. You notice it also stresses for more information, call this number, email this, what have you. Down there, if you look, it talks about who's eligible. It's always good to put that in so they'll know, so you won't have 150 people call you just looking for the money. You also need to put that there's no cost to them. Not that it's free, excuse me, but there's no cost. And that they may be compensated. Like this says for parking and study-related visits. That's like sometimes we cover them for travel time, mileage, things like that. This is another one about pain. As you can see, you can look through these later. I always put this in. I always like to have a few little jokes because, research sometimes, recruitment and retention can be a little dull. But you will see the patients like this. According to some websites I found, I've got all these diseases. I need a study. Okay. Recruitment firms, most of the time, I've never used them much in any aspect, usually using your clinical base of patient load. It gives you enough patients. You don't really have to look. Now, if you're looking at a phase 1 for healthy individuals, sometimes you might consider using a recruitment firm. Next frontier is the internet. We all know that. Everything is on the web. One thing to be aware of, though, for everything you put on the web as an advertisement for a study, there's somebody, some blogger in a basement in his mother's house that's going to tear it apart. So just be prepared. You need to You need to make sure when you put things on there also that you don't break any HIPAA guidelines and that you have already approved this through your IRB. This is talking about, and really if you read the FDA regulations about reimbursement, it's very vague. It doesn't tell you ABC, you can't, you can't do this, you can't do this, you can't do that, or you can't do this. It's real vague, and it leaves a lot up to the IRB to determine. And when you look at things, before you send something to your IRB, you need to have the true cost. I've put a little aspect of the slide in here that actually has the cost of like parking, what a visit costs, and the mileage for the state of Alabama state institutions. It's like 55 cents a mile or something. And you calculate all that into your visit. Most of the time, I look at this when it's talking about expenses and convenience, travel expenses. If you see a patient and you're doing a standard of care study where the patient's already coming every day for a month, every week for a month, and that fits exactly in on the same day as their research visit would, and they're not getting anything extra, you can actually draw their primary labs when you do their clinical research labs. That necessarily is not something that's an inconvenience. It's more along the lines of something that just really works. So you look at that. Look, if it's going to be a long period of time, do you cover meals? Because if these patients, especially in our business with an oncology patients, a lot of times they can't drive themselves. So you have to cover the caregiver that brings them up here. So those are things to look at. And once you figure out what you're going to pay, make sure you set that into your RB and you explain what you're paying for. This is what I was talking about, the reimbursement. For a 35-mile trip, it's like 56 cents a mile. The parking is $6, depending on which parking deck you park into. The typical visit is like $72, and so your total reimbursement is like $100. So, that's usually $100, $50 to $100 for a visit is usually not really looked at bad. When you get higher than that and you don't have the paperwork to match it, that's usually where you get in trouble. Okay, when you profile, I'm going to cover through this kind of quickly. Profiling by generations, it's learning what generation you're talking to. Now, most of you, if you've been in research a while, if you've been a nurse or a medical professional for a while, you understand the different generations out there. You have the radio babies, the baby boomers, Generation X, Generation Y, and the millennials. Usually if you're doing pediatrics, you'll see more millennials, and you'll actually see the 2000 babies. But these were looked at in 2007, so I'm sure there's something more later out, but I just haven't been able to find it yet. This talks about with their radio baby, what do they remember? You need to bring things into context when you're talking to them about things they remember, things they grew up with. One of the big things when I talk to people who are radio babies or baby boomers, especially in oncology, I always want to stress to them that the chemotherapy, the radiation therapy that they're thinking about is not what their parents got or their grandparents got. Because in Alabama, we've all heard horror stories of the radiation burned through their skin or the chemotherapy ate a hole in their skin, that kind of thing. So you want to take that away, but you've got to remember that's where their base is coming from. That's where their understanding and their ideation is coming from. Generation Xers, these people just want to know, is it going to benefit me, and is it not going to inconvenience me? They want to know, I've done all this stuff. I've survived the 80s and such. I want this to benefit me. The Generation Yers, these are definitely the ones that know computers. They want to see it on the web. They want to see multiple things on the web about it. They want to have it clarified to them, but they also want to know that this is what's best for me, or this is what everyone thinks is the best for me, and all my peers believe it's good. They're very high on wanting someone else to approve that what they're doing is good. These are the millennials. These are the ones that are 9/11 babies. These are also the ones that had helicopter parents, which unfortunately I have to say I'm partially a helicopter parent with my 22-year-old still. they care about what's happening in the world. They look at the world's not going to be around for them if they don't take care of it. So these are the ways you have to explain to them when they are understanding about, when you're talking to them about helping someone out later on. It will better mankind, things like that. They understand that, and they're looking for that. Okay, retention. This is going to be real quick. Retention is just making someone stay in the study. And you can't, as I said, you can't make someone stay, but you can help retain them by listening to them and talking to them and explaining any issues they have, any problems they have, and addressing them as quickly as you can. Biggest thing I talk about, human interaction. Any that are watching this, if you're nurses, you know you're taught in school, do not stand above the patient, look the patient eyeball to eyeball, listen to what the patient has to say, and address it. Address it specifically if you have to, but see how how their questioning is so that you'll know what's the best way to answer their questions that they get the most out of it. People, a lot of times, if you're honest with them about the side effects, they won't leave. If you don't tell them that the medications have certain side effects, or if you can't explain when they have a side effect what's causing it, they're going to start trying to pull away from it. Also, if you're not committed to them, they may not be committed to your study. Okay? So you have to listen to them. If they can't find a place to park, and here at UAB, that's a big issue. If there's no parking, they can't comply, they can't come in, and people will get frustrated. And believe me, I've driven downtown for years, and I get frustrated still trying to find some place to park, trying to get in somewhere. So you have to take that in consideration and address those issues when they come to you about it. You need to look at also family members. I always talk when I'm recruiting somebody, if there's family there, I try to bring them into the mix. My favorite line is I always say, look, when I'm talking to the patient, this is the study, but if you want to talk about it with your family, if you want me to leave and you discuss it, that's fine, because you're going home with them. You're not going home with me, and I want everybody to be on board before we consent. Because as soon as you consent somebody that son, daughter, aunt, uncle, they don't want them to be in the research, they hate the research, you're not going to have a very good research participant, and they're going to probably withdraw very shortly. Retention tools, give them a gift. Everybody loves a trinket. I don't see as much now in oncology as I did in CV. In CV, everybody got calendars or coffee cups or things like that. Sometimes it doesn't even have to be that much. Sometimes it's a pat on the back. Sometimes it's, how are your grandkids? That's a retention tool, because the patient believes you really care about them. Now, I'm not saying ask about their kids and then turn away like you don't care. I'm saying ask about their kids and look at the pictures and say, that's a beautiful young man, or that's a beautiful little girl. But that helps have that human interaction. That helps the patient maintain confidence in you. And sometimes if you run into a side effect that you don't know, and you look at them and you've got that rapport and you say, I'm going to find out what this is, but I really don't know. They'll believe you, and they'll trust you. You can read over these things, educational material, things such as that, websites you can send them to, but I stick more to the human touch. I think, especially in oncology, people are craving that. Okay, these are case studies. These are things that you need to look at, and once you get off the webinar, think about these for yourself. 55-year-old man has a very heavy workload. He's in your clinical trial, but yet his job is changing his route, changing things, and he's finding it harder and harder to come by. He's thinking about dropping out. How would you handle that? Next, Laura. She's a 60-year-old woman. She had started, and she was a gangbuster when she first started. She wrote down all her adverse events. She looked at everything. She was just very happy. But she got in with some of the ladies at her church, and they started telling her all the horror stories of clinical research back in the 40s. And then some of her family started saying, Mama, you're just being a guinea pig. They're just going to poke you and jab you. how do you need to handle that? This is one of my favorite ones. Harold is a 19-year-old. He's been in your study for 2 months. Study staff talk to other staff if he is not there as they go about their task. He feels like he's not appreciated. It says 19. That could be any age. Believe me, what you did last night with your husband, what movie you saw, what play you're going to, what vacation you've been back from, is not important when you're talking to the patient, when you have the patient there. The patient is your focus, and that's what it needs to be if you want to retain them. Like I said all throughout this time, the human touch, interact with them, and they will stay in your study. Okay, remember, it's a team effort. You have your PI, you have your coordinators, you have your data people. Everyone should work together, and that will bring the best success to your clinical trial. You'll recruit well, and you'll retain well. It's not enough to be the highest recruiter in a study. You want to be the highest recruiter that retained the most number of patients. Okay? Good luck. And one last thing, I leave this for you as a laugh before you go, because this is what I plan to do the first time I get FDA audited. I've already bought the hat for my physician to put it on his head. Thank you. If there are any questions, please feel free to contact me. My email is jhrichardson@uabmc.edu. Tell me what your question is, and I'll do my best to answer it. If I don't know, I might lie to you about it. But thank you very much. I hope you have an enjoyable rest of your day.